coordinator of WHO Cancer Day, counselor of International Academy of Oral Oncology, chairman of Oral Cancer Foundation, Indian Dental Association. He's founder of Cooperative Oncology Group. So he is holding many such positions, and if we start enumerating, 1 hour will go on that only. He has also achieved many awards, but the most important thing for today's, we all must remember that he has tremendous interest in public health issues, especially related to tobacco, areca nut, and alcohol control. He was invited as a speaker in United Nations Summit in New York in 2011 to speak on non-communicable diseases. So we all look forward to your lecture, Pankaj, today, and over to you.
So thank you, Kaustuv, for the kind introduction and also inviting me for this very important session. And I would like the students to realize that we want it to be more and more interactive rather than only a didactic lecture. So the topic assigned to me is oral potentially malignant lesion. I would suggest that anything related to any aspect of oral cancer, even if that is there in your mind, with a focus on precancerous lesion, please put your question in the chat box, and I'm here to answer all those questions so that by 8:30 when you leave, you are able to have as much information as much as possible with examination in mind, and also having in mind that India has the largest burden of oral cancer. Many of you will be going out in the community and working for early detection, prevention, treatment. So this knowledge is going to be very important for you. So first of all, let us look at etiology. How does oral pre-malignant lesions happen? Many of you will know that tobacco certainly is a problem, but what is also well understood and established that alcohol as a etiological agent is well established, and it's a group 1 carcinogen, and therefore when you counsel the patient, please inform them about the alcohol usage as well. Virus in precancerous lesion is not well known, but yet it is emerging. But what remains something enigmatic and something that all of you should practice in your day-to-day clinical ward rounds and OPD is counseling regarding the areca nut. Because areca nut is again a very strong etiological agent, and it is associated with precancerous lesion and oral cancer. And there is some evidence that fungal infection, candida infection may also contribute to causation of precancerous lesion. But what I have highlighted as a something which is in red color, please remember, whether it is tobacco, alcohol, areca nut, candida infection, they all come under the umbrella of poor oral hygiene. Because somebody who has a poor oral hygiene will also is likely to have other etiological agent. And if you see any patient in your clinic who is having poor oral hygiene, or a healthy subject who has come to you for many other things, non-oral cancer related issues, to them also you should promote oral hygiene. And I personally feel that if you all, and if we all work together in improving the oral hygiene, which encompasses all these factors, certainly we will reduce the burden of oral cancer in the country. And if you look at the intrinsic factor, yes, there are factors like people talk about the nutritional deficiency or immunosuppression, but there are at least 4 to 5 genetic predisposition factors like Werner syndrome, Bloom syndrome, ataxia telangiectasia, then xeroderma pigmentosa. So these are the genetic conditions where there is a higher predisposition for development of oral premalignant lesions. Quickly, let us discuss about the definition and terminology. There was a time when we all used to call them as precancerous lesion or precancerous condition. There's a difference between the two. Precancerous lesion is a morphologically altered tissue which is more likely to occur when it is apparently normal counterpart. That means when you have a precancerous distinct lesion which may have a malignant transformation, that is a lesion. However, there can be a situation where entire buccal mucosa is abnormal, like lichen planus, other submucous fibrosis. These are precancerous condition because there is no lesion as such, but these conditions predispose to having precancerous lesion or oral cancer. So in 2005, when this confusion was happening, the WHO defined the oral premalignant lesion as the risk of malignancy being present in a lesion or condition either at the time of initial diagnosis or at future date. That means the lesion and the condition were merged into a single definition. And then came the latest definition, which is 2020 definition, where it says any oral mucosal abnormality that is associated with a statistically increased risk of developing oral cancer is called oral OPMD, that is oral potentially malignant disorders. So now this is very clear that whenever you are asked about a definition, it is the latest definition that we have. In 2020 classification, these two were added and one was excluded. So let us see what was excluded. In the older classification, even oral epidermolysis bullosa, that is OEB, was included as a OPMD. But now we know that there is no linkage, but what has been added is the oral lichenoid lesion. Please understand, oral lichenoid lesion. These are the lesions that have features of the leukoplakia but lacking typical clinical appearance of oral leukoplakia, oral premalignancy, and this shows asymmetry or are reactions to the dental restoration or are drug induced. The next is the oral graft versus host disease, OGVHD, and these are clinical and histopathological presentations similar to oral lichen planus in a patient developing in an autoimmune or multi-organ complication after BMT. So these two are also added in the OPMD list. Now, let us spend time 2 minutes on this slide. So there are pre-malignant lesions and there are pre-malignant conditions. So this distinction is very, very important for you to understand. Pre-malignant lesions can be treated. Pre-malignant conditions, we can't treat them by localized treatment. It has to be something called a systemic treatment. Now, if you look at the pre-malignant lesions, they are leukoplakia, erythroplakia, proliferative verrucous hyperplasia, reverse mucous palate, candida leukoplakia, and actinic cheilitis. And in the pre-malignant conditions, we have oral lichenoid lesions, oral lichen planus, oral submucous fibrosis, oral lupus erythematosus, GVHD, and disc keratosis congenita. So when you look at the right side, these are the situation where you don't find a lesion, but you have to put them in a very strict surveillance because some of them will develop either the pre-malignant lesion or they develop cancer, and therefore they have to be counseled for regular follow-up in your clinic. However, the one on the left side, depending on the condition and presentation, they may require immediate treatment, be it surgery or medical treatment, or again, some of them can be put into the regular surveillance. Now, this was a very, very old paper, and it does talk about what are the high risk features which can tell you about the malignant transformation. Now, female gender, long duration, leukoplakia in non-smokers, location on the tongue and floor of mouth, size more than 2 centimeters square, non-homogeneous type, presence of Candida albicans, and presence of epithelial dysplasia. In this, I would only suggest you to remember three things. One, four things. One is long duration of leukoplakia. Any leukoplakia which is there for a long time is something as a malignant transformation. Second, size more than 200 millimeters square. It is very important. Larger the leukoplakia, higher is the malignant transformation rate. Similarly, heterogeneous leukoplakia has a high chance of conversion into malignancy. And last is presence of epithelial dysplasia, which will happen only when you have taken the biopsy. So these four features, if you keep in your mind, it will guide you about the extent of counseling, surveillance, and follow up that you will advocate to the patient when he presents with a OPMD. Now, these are oral OPMD and a systemic review and meta-analysis of malignant transformation. Because when patient comes to you, he is always tense and he is always worried because through WhatsApp, through social media, he knows that it is a precancerous condition and he is asking you that how do I predict my malignant transformation rate, or how do I assume what would be my future. In that condition, the statistics is very important because the entire surveillance plan depends on these malignant transformation rate. Now look at the leukoplakia and erythroplakia. The malignant transformation rate is almost 1.56%, but almost 2%, and for erythroplakia it is 2.7%. That means it is per year. Longer the duration, when I say malignant transformation per year, means that 1.5% and 2.7%, and the longer he lives, and here is a cumulative rate. Look at this cumulative rate, 33.16, and here it is 8.6. That means we have to tell the patient to be more on intense follow-up when we are dealing with erythroplakia. We are dealing with proliferative verrucous leukoplakia. Maybe you want to see them 4 to 6 months or every 4 to 6 months. And then lichen planus, oral OLP, and this oral submucous fibrosis. Again, it has a malignant transformation rate, but the severity of the follow-up or the duration of the follow-up can be still longer. So this statistics tells you to personalize the surveillance strategy for the treatment of oral premalignant lesion based on the features they have. Now here, if you see proliferative verrucous leukoplakia 49.5%, I personally feel when you see them, they should be treated. You should be able to take it out. The reason is that 49.5% cumulative risk is like toss of the coin. Half of them will have it, half of them will not have it, and they are already anxious. And therefore, for such patients who present on proliferative verrucous leukoplakia, I prefer doing surgery on them at the time of presentation itself. Similarly, erythroplakia, I usually do not want to put them in surveillance. If patient is presenting, I'll counsel them for their habits, and if the habits have gone down and patient is having no more etiological agents in his lifestyle, I may plan to do surgery on erythroplakia as well. Now, for India, the natural history is very, very important because there are two kinds of pre-malignant lesions. One you see in the community and the other you see in the hospital. And this distinction is very, very important. When you go to the community, many of the time what you pick up is a asymptomatic, non per year. But when the patient comes to the hospital, he is symptomatic, he has a large leukoplakia, he has a visible leukoplakia, and he is having some habits and all that, which he, through social media, he realized that it is bad and he has come. So if you are seeing a leukoplakia in hospital and you analyze their data of malignant transformation, it may be up to 40 to 50% because there is a selection bias and only worst leukoplakia and worst lifestyle has come to the hospital, whereas healthy people, small leukoplakia, no visible lesion or no symptom, they are still there in the population and their malignant transformation rate is lower. So this is a study which was done in Gujarat, and the thumb rule that we always follow, because this is again something that is based on geography. So in Gujarat, 11% of the leukoplakia increased in size after 2 years. 31.6 decreased in size or disappeared, and 57.3 remained unchanged. So the thumb rule that I always tell my students is 50% of the leukoplakia will remain unchanged, around 30% will decrease in size, and around 20% will increase in size. So 20% increase, 30% decrease, and around 50% remains unchanged. So again, in your surveillance strategy and your counseling, this is very, very important. Based on the advantages of detection of leukoplakia, ease of detection of the leukoplakia, and its malignant transformation rate, an intervention study was planned in Ernakulam in oral cancer for oral cancer mortality reduction, and the study found that if health worker are able to do door-to-door survey of pre-malignant lesions and they are able to refer them to a clinic, then in that population, visual examination done by the health workers in the population where oral cancer is very common, this intervention led to reduction in mortality due to oral cancer. So you can imagine oral cancer, which is the number one cause of cancer-related death in Indian men, it is so common. In this, the best screening tool that we currently have is visual examination by health worker. But the problem with the visual examination is that we are perhaps having the cancer detected at much later date when the process is still irreversible. So if you look at the whole pathogenesis from normal mucosa to an advanced cancer, it takes 10 to 15 years. And what we are detecting is perhaps oral leukoplakia at a stage where it is only 4 years or 5 years of whole process of carcinogenesis. And at that stage also, as I told you, that there is a chance that around 30% malignant transformation may have. So perhaps we have to move much earlier than when the leukoplakia has already happened, and that can happen when we go to the microscopic level or ultra microscopic level, because the whole carcinogenesis is very, very designed. It is temporal, and perhaps we can plan some strategy for early detection where we can truly prevent cancer rather than prevent cancer in a small percentage. Now, I'll just run past the next few slides so that we have more time for questions. Now, there are a lot of screening adjuncts. As I told you that oral visual examination is not perfect. Some people still have oral cancer despite the visual examination, because the outcome of the pre-malignant lesion itself is unpredictable, and we do not have a real thumb rule that how many will truly develop cancer. So there are a lot of adjuncts, and there are adjuncts in clinical imaging, histopathology, and optical methods. Now, clinical, there are, vital staining. So vital staining and like toluidine blue and Lugol's iodine. So what it does, it differentiates the normal mucosa from the abnormal mucosa, and wherever the abnormal mucosa is there, it is likely to be pre-malignant, and you can direct your biopsy. In India, because of the prevalent smokeless tobacco usage and areca nut usage, vital staining has a lot of false positive, and that is why it is not popular. Now, optical methods, there are multiple: visilight, microlux, Wellscope, fluorescence spectroscopy. In one word, I can say that these optical methods work well in the clinic when a doctor is using it, and they use it judiciously, but none of them have been found to be useful for screening in the population, where a lot of false positive will lead to very low negative predictive value and abnormal positive predictive value, which is not acceptable for screening. Similarly, we are all doing studies on optical coherence tomography, narrowband imaging. They're all not useful for population-based screening. They are good for some research trials at this point being done in academic centers and clinics, but not available commercially for early detection of oral cancer. Similarly, I would strongly suggest that you go for scalpel biopsy or a punch biopsy whenever you have a lesion leukoplakia. Don't go for oral CDX brush biopsy or brush cytology, because the false negatives rates are very high. And the reason is that most of our leukoplakias are superficial, thin layers, and there it is very difficult to obtain the full thickness, because for pathologists it is important that you give them the normal tissue, and the lesion can be ascertained as an invasive cancer or a carcinoma in situ when full thickness of the suprabasal layer and the stroma and the basement membrane is available, which is not possible when you do a brush cytology or a scrape cytology. Now, this is again quickly telling you in exam, you may get it, this question of comparing the diagnostic accuracy and in the index test in the detecting pre-malignant disease or squamous cell carcinoma. So this is the 41 studies and 4,002 participants, and you can imagine that oral cytology has the highest sensitivity and specificity, and that is something that we can promote. But the bottom line is that none of the adjunctive test can be recommended as a replacement for the currently used standard of a scalpel biopsy and histological assessment. Now, the biggest problem why pathology is a problem, though we are saying it, that there is a huge inter-observer variability. There is a lot of subjectivity involved. So whenever you give the same slide of oral pre-malignant lesion for classification of the mild, moderate and severe dysplasia to different pathologists, you will be surprised that all pathologists will give different. The reason is there is a subjectivity involved, and that is why you cannot strongly rely on dysplasia alone for production of the malignant transformation. Now, there are a lot of salivary biomarkers. Some of you would like to know that are there any salivary biomarkers? Quickly, I'll tell you that lot of salivary biomarkers have been tested in the academic centers, like interleukin 6H, and then there is human beta defensin. Then people have looked at some other microbiome. In bottom line, I would say that this is a work in progress. There is no currently available salivary biomarker or a spit test which can help you develop a point of care device, POC device, for early detection of oral cancer. Now, this is again a compilation of multiple studies where we have looked at what is the efficacy of variety of the treatment that we give. Now, this question is asked that should we excise the leukoplakia or not? If we excise the leukoplakia, should we use laser? Should we use scalpel or not? So quickly, I'll tell you. Whenever there is a high risk of malignant transformation, that means you are dealing with a heterogeneous leukoplakia, large leukoplakia, symptomatic leukoplakia, bleeding leukoplakia, suspicious leukoplakia, these lesions must come out. When you say come out, that means there has to be a margin of at least 3 to 4 millimeter, not typically 1 centimeter or more than 5 millimeter that we ask for. 3-dimensional, you have to remove this leukoplakia. And it is known that if you excise the leukoplakia, you have histopathological examination, so you can classify them into high risk or low risk. B, you can have the planned surveillance strategy. And C, it is very important that it is known that if you excise a leukoplakia, the chance of malignant transformation in that particular lesion is taken care. Now, whether to use laser, whether to use scalpel is again laser. If you have, you can use it. If you don't have it, it is not a crime to use cautery and knife or removing the leukoplakia, because there is no great evidence to say that laser is superior to a knife for preventing the malignant transformation rate. But for comfort of the patient, for wound healing, perhaps laser is superior to knife because it is certainly less ablative. What is important that there should not be any fulguration, and you should not be burning the leukoplakia with cautery or laser, because what is important that whatever you excise as a leukoplakia, as I told you, it has to be removed with a three-dimensional margin. And second, this should be available for histopathological examination. Therefore, no fulguration should ever be done. The choice between the laser and the knife, I have already told you. The next question that comes is that, and it is a very, very, I would say, very, very common malpractice that is happening. And I'm strongly using the malpractice. When a patient of leukoplakia comes, I see patients coming from different medical colleges and dental colleges and private practitioners. We prescribe them n number of medicine. There is no such evidence. There is no medicine which can prevent malignant transformation. And whatever you are giving to these patients, we are benefiting the pharmaceutical industry, but we are not doing any service to the patient. So this practice should immediately stop. What is important for malignant transformation reversal or stoppage? Patient has to stop the habit. He has to come for regular follow-up. He has to improve his regular diet. That means whatever fruits, vegetables, and all that you want to promote is fine. But there is no currently chemo prevention agent that can be prescribed to the patient, and it should be stopped. We have done some studies in high-risk leukoplakia using the erlotinib, but again, this is a work in progress, and this is still a research subject. Some of you would like to know what is the role of photodynamic therapy. So I can just say in 2-3 words, photodynamic therapy as a concept is fantastic. There is no doubt about it. It allows you to target your entire therapy to area of suspicion, which can be picked up by using the aminolevulinic acid or so many other photodynamic therapy agents that are available. However, as a intervention or implementation of this concept is a problematic, and that is why, though conceptually it is a great concept, but is not great in terms of localization. Third, it is not something which is freely available. So with all this background, this is still a work in progress, and I cannot say that this is being used. Like in our own hospital, we have never used it. Now quickly, I'll tell you in next 4 or 5 slides. I'm just demonstrating the clinical presentation. On the left side, you see a small, thin, homogeneous leukoplakia. This leukoplakia, if you see the teeth, that means the person is using smokeless tobacco or areca nut. For me, the immediate strategy is that this patient has to be counseled and he should stop his tobacco habit. And this small, thin, homogeneous leukoplakia can be observed. There is no need to rush for biopsy at this point. However, if you see a lesion, as in right, there is a large leukoplakia, heterogeneous leukoplakia, and this patient cannot be ignored. Here the biopsy is essential, and the biopsy should be taken from the heterogeneous area and the thickish area where you will feel induration. Then you see sometimes these oh my god lesions where the entire buccal mucosa is covered or entire half of the tongue. These lesions have very, very high malignant transformation rate, and it is unlikely that you can put them in surveillance or put them in some observation or chemo prevention. It will not happen. Most of them require surgery, though it is going to be the morbid surgery, but there is no way you can do anything less than that for these patients. On the left side, you see a large erythroleukoplakia. Malignant transformation rate, as I told you, is almost upward of 30%. It needs to be surgically excised. There is no point in putting them in surveillance again. On the right side, you see that many a times patients who are having submucous fibrosis after a hot food or a cold food or something spicy, they develop these inflammatory changes in the mucosa. This is not erythroplakia. This is the traumatic or inflammatory process that happens in submucous fibrosis. So you need to distinguish between erythroplakia and these inflammatory lesions. So erythroplakia is like a red velvety lesion, and that is why you need to classify them. This is a special thing that you see in India. These are called verrucous leukoplakia, and these leukoplakias, their malignant transformation rate is almost 50 to 60%. Whenever you see a lesion like this, the only treatment is surgery, and you treat them like a cancer, where you have to take a wide margin, 1 centimeter margin. Even if this patient requires marginal mandibulectomy, you may have to do it because margin is very, very essential. And what is critical is that these patients, around 11% or around 10% of them, in the histopathology, they will have verrucous carcinoma. And therefore, if such a lesion comes, I do not shy from doing the neck dissection also, because many of them will require microvascular reconstruction, for which neck access is very, very important. Now, this is a typical lesion where you do a biopsy, the biopsy comes negative. You fight with the pathologist that I see a lesion, why can't you? The problem is that this lesion is called verrucous lesion, Ackermann's tumor. It's a purely clinical diagnosis. You should not expect pathologists to ever guide you for obtaining the positive biopsy. Only in histopathology you will be able to get a positive biopsy, not in the OPD biopsy or clinic biopsy. And therefore, surgery is not only diagnostic, but surgery is also therapeutic. Now, submucous fibrosis is an enigmatic disease which happened in Indian subcontinent. It is exclusively linked to areca nut usage. Smokeless tobacco does not cause it. Alcohol does not cause it. Smoking does not cause it. It is only because of arecolin, areca gene, which leads to excessive collagen synthesis, cross-linkage formation, and stabilization of the collagen fibrils, which leads to submucous fibrosis. It's a pre-malignant condition. Around 7.5 to 8% of them will have malignant transformation. It's a highly symptomatic disease. Patients are not able to take cold food, hot food, spicy food. They live in misery. Unfortunately, there is no treatment currently available. The issue is that there are a lot of treatment available for oral submucous fibrosis. If you go in the textbook, it is all over. When you have multiple treatment available for anything, that means there is no good treatment. And therefore, what I do, that if this is a Khanna Andrade classification grade 4 submucous fibrosis, where oral opening, mouth opening is less than 1.5 centimeter, less than 1 centimeter, I plan to do surgery on them. Anything more than that, I put them on conservative treatment. Or if they already have a lesion which warrants surgery, we will do that. And this, in Gujarat, there is a surge of oral cancer. In many parts of India, it is exclusively because of the pan masala usage. Gutka has been banned, but pan masala is available, and all celebrity endorsement is there. IPL, all cricket matches, Filmfare Award, the Cine Awards, they're all sponsored by the pan masala industry, and that has led to a very epidemic proportion of oral submucous fibrosis in our population. So the take-home message is that malignant transformation rate of OPML depends on the type of the lesion. Oral visual examination is the most cost-effective tool. None of the adjuncts are proven to be effective. Histopathology is still the gold standard for diagnosis of the OPML. Salivary biomarkers do have a promising role, but still under evaluation. Excision of the pre-malignant lesion reduces the risk of malignant transformation, and none of the chemo-preventive drugs are proven to be effective. What is most important and the take-home message: whenever you see a patient who is having pre-malignancy, please counsel them to stop the etiological habits. And if you see any other patient who has not come for oral pre-malignant and the relatives are using tobacco, alcohol, or a recurrent, if it is evident, counsel them not to have it. Thank you so much.
Thank you so much, Pankaj, for an excellent elaborative overview over these important lesions which we come across in day-to-day OPD. There are some questions. The question from Abhishek says that whether proliferative varicose leukoplakia and erythroplakia, how much margin we should take, and if it is abutting alveolus, would you consider doing marginal mandibulectomy? Abhishek, your answer was given in the lecture. You asked it a little earlier, so that's why there is a question. Pankaj said that we must take adequate margin, that is like cancer, and we can do a marginal mandibulectomy also, because many of these ultimately in final histopathology can show invasive cancer. I'm not finding other questions. People are really, they have, I think, understood so well that there are no questions to you, Pankaj. But I have a question. Pankaj, can you tell us how frequently we should follow these patients? What should be the frequency of following them?
So we have to personalize the entire follow-up according to the risk of malignant transformation. For any lesion, heterogeneous leukoplakia, bleeding leukoplakia, leukoplastia sometimes looks very angry as in patients are very symptomatic. Biopsy is negative, surgery they are not willing for. So those patients, I put them on very close follow-up, and that could be as close as 3 monthly. But for those patients like submucous fibrosis with no distinct lesion or lichenoid lesion, or patients having early homogeneous small thin leukoplakia, I may call them 6 monthly. But I keep telling them, and that is what empowerment we have to do. I usually tell them and their spouse, and if it's a child, the mother and a wife, they are two very, very important components in my surveillance. I tell them that you monitor the lesion. If there is any size change or appearance change, please bring earlier than what I'm suggesting.
And the corollary to this question, that if we have excised the leukoplastia and patient has stopped the habit, we must follow him up still. I mean, that is something we need to emphasize on students, that these patients, the moment they stop, the risk is not going to become zero.
You are absolutely right. Many of these patients, they come back and tell you, that's all, मैंने ना 10 साल पहले तंबाकू छोड़ दिया था. So you are very right, Dr. Patel, that the risk of malignancy and malignant transformation rate reduces after cessation, doesn't become zero at all. And therefore, even after excision, such patients require follow-up because field cancerization is still there. The entire upper aerodigestive tract mucosa is still having condemned mucosa, which is likely to convert into malignancy anytime. And second primary tumor is 1% per year. So maybe after 10 years, there is a 10% chance that he will get a primary elsewhere in the oral cavity or upper aerodigestive tract. And therefore, it's a lifelong surveillance, and that is what people have to understand.
Thank you, Pankaj. And another question is from Rakesh Bharat. There are in fact two questions. One is how to assess oral hygiene and how to standardize the findings. And the second one is what is the management protocol for oral submucous fibrosis?
So the first question is for the oral hygiene. So there is a decay, missing, filled teeth, DMFT index. So that is a very standard index because we need to convert the hygiene as a more objective way of assessment. So DMFT index you can look at, and it's a well proven and well studied and internationally followed. So we can use that. Now, coming to the oral submucous fibrosis, as I told you, that currently there is no treatment protocol which I can really suggest. I showed you the entire set of slides, including the intralesional steroid injection, then band release. Actually, you have to look at the patient. If the patient has a very less mouth opening, which is leading to his inability to take food, or even oral hygiene can't be maintained, in such patient perhaps you can start with band release, but ultimately you may have to go for bilateral coronoid release and a massive surgery with reconstruction. For any other patient, if you really ask me, many things have been tried for symptomatic benefit, but none are actually proven. What patient has to do, whatever hurts him or her, he or she has to avoid that.
Pawan Gupta has asked, probably Pawan Gupta is the same who is again a leader in
tobacco
control in India. He has asked, how long do we wait for stopping tobacco before we go for intervention?
See, it's all subjective. I usually don't force them, because I know it's not easy for anyone to stop alcohol, tobacco, areca nut and all that. What happens that if you treat them immediately as soon as they come, they do not have the fear or adherence to tobacco cessation guideline. If you tell them that I can't treat you unless you stop, they may come back and say in 1 month, because they are very afraid. In 1 month, they will be able to quit. And that is a thumb rule, that if people are able to quit tobacco for 4 to 6 weeks, it is unlikely that they will relapse. There are relapse rates, and that is why I use this fear factor for the diagnosis of the oral pre-malignant lesion. And if it is not a very morbid surgery or procedure, I may do it within 2 to 3 months. But sometimes when you have to do microvascular reconstruction or a large like proliferative varicose leukoplakia, when they are recent smokers, their lung compliance is poor, their effort tolerance is less, and anesthetists also are not comfortable giving anesthesia, there I have to be very strict as soon as our anesthetists also are very confident. Till such time we wait.
Abhishek Verma has asked, do traumatic ulcers due to sharp tooth have malignant potential?
See, what happens that sharp tooth by itself, it is a promoter, it is not an initiator. That means the entire carcinogenesis pathway actually is an inflammation pathway. If you look at all the molecular markers and the whole pathway, it is all a chronic trauma. What areca nut does, chronic trauma. They're all adding to the carcinogenic potential of tobacco, alcohol, areca nut, which chemically induces cancer, and it is promoted by the poor oral hygiene and missing teeth or trauma and all that. Though we have published that trauma itself alone can have an etiological role, but what happens in a population where 70 to 80% of oral cancers are already because of tobacco, I cannot find a large sample size to prove my hypothesis that by adjusting tobacco, I can find whether tooth trauma alone is causative for oral cancer. So the short answer is that if you see someone having sharp teeth, please send them to dentist for grinding, because it may have potential role in promoting carcinogenesis.
Pranjit Kalita has asked, which classification for trismus we should quote?
Khanna Andrade classification is there, which is quite prevalent, and you can use it.
Gesok is asking, is HPE is a gold standard for diagnosis, or is it clinical diagnosis?
If you are working in community, there are two layers of triage. Once you are working in community and you have seen a lesion, you should refer all white lesions to the tertiary care center or secondary center. When you are in the clinic and somebody has come to you, that means that patient is having suspicion, he is having symptom, and he is worried. In such patient, histopathology is the gold standard unless you are still having less than 1 centimeter thin homogeneous leukoplakia, compliant patient, willing patient who is willing for follow-up regularly. Otherwise, better to do a biopsy and confirm whether it's a severe dysplasia or cancer or not, because in a country where oral cancer is so endemic, unless proved otherwise, every oral lesion is likely to be malignancy or pre-malignancy.
Very well said, Pankaj. Another question and a common phenomenon coming to the head and neck surgical oncologist is the patients who has been treated with steroids before coming to you who has a leukoplakia. So the question is, local steroid application, does it increase the risk of malignant conversion?
See, first of all, if the local steroid application is being given for oral pre-malignant lesion reversal of malignant transformation rate, it is not evidence-based. So I don't promote this. It may lead to some minor symptomatic benefit, but again, there is no evidence in submucous fibrosis. I would suggest that first of all, we should not be using it. And if we are using it for long term, then we should certainly not do it, because short term sometimes patients have problem, we can do it. I'm not sure whether it promotes malignancy, but it certainly promotes patient's tolerance, self-treatment, and his desire to go to a doctor and get him checked, when actually this could lead to delay in treatment.
So very well said, Pankaj, because these kind of patients, whenever they go to general practitioners or some dermatologist who decides that this is lichen and then they start steroids, but it needs to be looked at properly whether the treatment is right or not, and I'm sure that the students will benefit from your suggestion of not giving steroid for leukoplakia. Oral mucosal pre-malignant lesion during follow-up, how is the lesion follow like? Do we take photos serially, or it is done in a senior specialist hands as a practical kind of a follow-up?
Very good question. So here I would suggest, I always, in all my patients, I empower them to take charge of their own health. It is not the responsibility of the doctor to really spoon feed them. I tell them that this is the picture, you keep it with you. And because see, many of these patients keep doing the doctor shopping. They go from one place to the other place. And why they do doctor shopping? Because there is no treatment for leukoplakia. They are concerned we are not able to give them any offer treatment, and every morning they get up with the fear that they are getting cancer, so they keep shopping doctor. At that point, every time you go to a new doctor, he will start his own cycle of analysis and evaluation. To avoid that, I tell the patient that you serially maintain the photographic picture of your lesion, which I might take and give it to them. But picture is very, very important. The reason is that if I do a biopsy of a lesion and then this area becomes inflamed, this patient goes to see Dr. Kaustubh Patel. Dr. Kaustubh Patel will see a whitish area with the center having inflamed and reddish area. His degree of suspicion will be even more than me, because he has not seen the treatment naive lesion. He has seen a biopsied lesion, inflammatory lesion, and perhaps he will do another biopsy. And when he do another biopsy, it only leads to submucous fibrosis, flare-up of the entire inflammation. See, the whole pathway of submucous fibrosis is there is an increasing collagen synthesis, decreasing vascularity, and strangulation of the vessel, and that is why it is causing blanching. That means there is hardly any blood supply in the mucosal area. So imagine if you keep repeating the biopsy, it only aggravates the trismus and submucous fibrosis pathway, and that is why maintaining the picture and the history is very important.
This is a very good message to take by everybody, that the evaluation of leukoplakia in serial in follow-up is objective and not subjective. And to become objective, this lesion needs to be documented properly by a photograph with the patient. This is a very good suggestion, that patient keeps their own photos, so that even if they go to some other consultant, they get transferred to some other city, at least the other consultant will be able to understand what was the initial lesion and what is the progress. Pankaj, Dr. Gupta is asking what we do after excision of leukoplakia, skin graft, anything else. I think, Dr. Gupta, it depends on the extent of the resection. If it's a very small excision, you may leave it raw, but otherwise skin grafting or reconstruction might be needed. At what definite size of leukoplakia should we excise the lesion? That is the question.
Anything which is more than 1 centimeter, I usually excise. The reason is that the malignant transformation rates are very high in such patients. Moreover, what happens that 1 centimeter is something which is visible to the patient and the relatives, and they are very anxious. Anything which is less than 1 centimeter, and again I'm saying that don't go by this thumb rule. If it is something 8 millimeter or 9 millimeter, what is more important, and if you have a compliant patient, if you have a symptomatic patient, if you have a patient who has a strong history of tobacco use and all that. So basically, this is all a personalized treatment that you have to give rather than going by the book.
There is a question after excision of lesion that are not involving underlying musculature. Can we leave the defect raw and heal by secondary granulation, as there will be fibrosis and consecutive decreased mouth opening? So again, this is on extent of disease, and if you need to reconstruct it, if it is a large defect, even with a microvascular reconstruction or local flap or a pedicle flap, depending on the extent of disease, because otherwise these patients are going to have more trismus, and then again that is a problem. Can we keep mild dysplasia under observation, or it's better to excise them? Pankaj.
So, very good question. See, please understand, mild dysplasia, moderate dysplasia, severe dysplasia, as I told you, it has a huge subjective variation. I would rather not rely singularly on the dysplasia status in the histopathology. I would look at the clinical examination, which includes history as well as palpation, and then look at the entire picture and take a decision, because mild dysplasia also, in a case we had large leukoplakia or heterogeneous leukoplakia or a symptomatic patient, can still have malignant transformation.
There is one question: mechanical mouth opening devices are good or not for trismus care?
See, mechanical mouth opening device are essential so that the patient is first you have to understand what is the pathogenesis of the trismus in the patients who are having submucous fibrosis. What happens that in the epithelial level, there is excessive collagen formation, excessive cross-linkaging happening, and that is why they have trismus. When the mucosa shrinks, the adjoining muscle, the buccinator, the trismus, the pterygoids, they all undergo disuse atrophy. The reason is that the patient's mouth is not opening, and those muscles are under disuse, and that is why they are getting shrunk, and that leads to progressive trismus. And that is why even if you do band release, the mouth opening will never improve. The reason to do the jaw stretching mechanically is to ensure that the muscles are still stretched so that they can remain more active even when the mucosa growth or mucosa, I would say, contracture is improving over a period of time.
Thank you, Pankaj. There are a few questions which definitely had answers in your lecture, and I would urge students to go to the NBME National Board website and can again go through this entire lecture. All the lectures are stored there on the website, and you must take advantage of these lectures. There is one question is, while doing surgery of oral squamous cell carcinoma, if we find adjacent diffuse leukoplakia, should we excise it? Yes, we must excise all the pre-malignant lesions in the oral cavity during cancer surgery so that you don't have a second malignancy or recurrences of this disease. How to judge whether leukoplakia or oral pre-mucosal malignant lesion reporting is good by pathologist? Any specific thing to look for in the biopsy reporting? Pankaj.
Yeah, so I would suggest that the biopsy should be done to exclude malignancy. That's it. For me, the biopsy is not a means to classify a leukoplakia into several layers of dysplasia. If you have done a biopsy and the biopsy is cancer, you treat like a cancer. If it is not a cancer and if it is clinically not happy, you are not happy with the lesion, still you do the surgery for the patient. So please do not use biopsy to avoid surgery when indicated.
So Pankaj, I think we have finished all the questions, queries from students, and this was a very fruitful learning, not only for students but for me also. And thank you so much for being there. And I'm really happy to tell the students that Dr. Pankaj is an ardent academician, and he's always ready to teach students. So you may contact him if you want any further questions to be answered. Thank you so much, Pankaj.
Thank you. Thank you, everyone. Have a nice day.
Thank you, training and faculties, for joining the session. Thank you, sir. Thank you so much.
Thank you. Okay.
Bye.
Bye-bye.